Hello, my name is Dianne Rudolph. I am a nurse practitioner and a wound care specialist. I am actually certified with the Wound Ostomy and Continence Nurses Society as a CWN nurse. And I'm very happy to join you today to discuss the science of wound healing. Just to briefly review, these are a few objectives that we'll be touching base on as we proceed. As part of this presentation, we're going to identify at least 2 ways to classify wounds. There are quite a few different ways, but we will touch base on several of them. We will describe the differences between full thickness and partial thickness wounds. We're also going to discuss at least 4 parameters to include in performing a systematic wound assessment. That is a very, very important skill for clinicians of all levels to be able to master. It is absolutely critical for so many reasons that we'll talk about in a little bit. We will identify the phases of wound healing and discuss the management of infected wounds. That's also a very important concept. Sometimes wounds that are infected, especially in chronic wounds, don't always have some of the classic telltale signs, so we will discuss that. And we will talk a little bit about some basic principles of wound management. So why is wound assessment important? It's really critical for a number of different reasons. It really helps us to establish a baseline. We have to have a starting point. We have to know where we are in order to come up with a plan of care and figure out how we are going to take care of this wound in this particular patient. It also gives us a cornerstone for establishing a plan of care. It gives us a way to measure progress, again, allowing us to determine whether or not what we're doing is effective or if we need to make changes. It's extremely important in terms of allowing us to justify reimbursement, and in this very cost-conscious society that we're in these days, our documentation is absolutely critical. It also helps us to establish a clear and accurate picture for the reviewer, and by reviewer that could be another clinician that you're communicating with in terms of the status of a wound. It could be, again, a medical reviewer or health insurance adjuster who is trying to see if what you're doing is accurate. Even from a legal perspective, that can be very, very critical. So again, wound assessment is such an important cornerstone that really allows us to determine a plan of care and help us move on to properly manage patients. So in terms of wound classification, one way by which we can classify wounds is surgical versus non-surgical, acute versus chronic. And that's really critical because when we talk about an acute wound, generally we are thinking about a wound that for the most part occurs in a healthy host and will usually heal according to a normal wound trajectory. Generally that might be a healthy 55-year-old who has an appendectomy with a surgical wound. It heals no problem. It might be the 70-year-old who's a fairly healthy person who gets a small burn or cut while working in the kitchen. It heals with no problem. The chronic wounds, however, those are the wounds that give us the greatest challenge as clinicians. And the best way to think about a chronic wound is that it is a wound that typically occurs in an unhealthy host. This is often a sign of an underlying disease process, and this will make more sense as we go on. But just by way of example, chronic wounds are wounds that normally don't heal according to a normal trajectory. And as I mentioned, they're also usually a sign of an underlying problem in the host. For example, a diabetic may develop a diabetic ulcer. A patient who is immobile may develop a pressure ulcer. A patient who has an immune-compromised state may develop a wound that was initially acute, a surgical wound, for example, that just does not continue to heal and becomes chronic. So that's a very important distinction, is just understanding that difference between acute versus chronic. Also, the depth of the wound is very, very important because a full thickness wound, for example, heals by a slightly different process as compared to a partial thickness wound. And the stage of the wound is also very important. But a caveat to this is that wound staging is really only applicable to pressure injuries. Now you'll hear me discuss in this particular slide and in subsequent programs pressure injuries, and that is the new terminology. We are no longer referring to pressure ulcers as pressure ulcers, but rather as pressure injuries. And again, when we are staging a wound, that is specific only to wounds that are pressure injuries. Also, according to the etiology, what is the cause of the wound? That is another way by which we can classify wounds. Now, in terms of wound depth, again, you'll see on the screen that there is a whole trajectory here. We basically go from intact skin, where there's really no obvious skin impairment, there is no break in the skin. We then can proceed to a superficial break in the skin, where again there is no longer the integument, the skin is no longer intact, but there is an opening, but it's very superficial, there's no depth. Partial thickness, again, in that case we have usually gone through the epidermal layer. And full thickness, where we have gone through the epidermal and dermal layers, and at that point we are looking at wounds that are, for the most part, subcutaneous in depth. There might be subcutaneous tissue exposed, there might be muscle, bone, you might even be in a joint or a joint capsule. So those again are very, very serious. So as we look at this trajectory, we can certainly appreciate the fact that as we move from intact skin to superficial to partial thickness to full thickness, we can appreciate that these wounds become extensively more involved and that there is generally more tissue destruction associated with the full thickness wounds. In terms of a skin cross-section, again, just to show you a little bit about the skin anatomy, and again to try to maybe elucidate further or clarify what we mean by partial thickness versus full thickness. And as you will see in this slide, this is just a very typical cross-section where you have the epidermis. And when we are talking about a partial thickness wound, we are talking about a wound that has not extended past the epidermal or dermal layer. When we have a full thickness wound, however, we have now gone beyond the dermal layer and we are in what's called the hypodermis or subcutaneous tissue. That's a very important concept to keep in mind, because partial thickness wounds and full thickness wounds heal differently. This is just to show you on these slides a couple of examples of what we would call partial thickness wounds. Now, as you are looking at this slide, you can see on your left-hand side, this is a very shallow wound. This wound, there is absolutely no depth. It looks as though the top layer has just literally been sheared off and you are just looking at some exposed dermis in that case. And then on the wound on your right, again, same thing, you're looking at some exposed tissue. You have no longer an epidermal covering. You are looking at exposed dermis. This is not full thickness. We have not gone past the dermal layer. We have not gone into the subcutaneous tissue. So these are partial thickness wounds. A couple more examples on your left. It looks like a very small superficial wound. And again, there's no depth. If you measure these wounds, you're really not going to have very much depth at all. If anything, perhaps 0.1 millimeter sometimes will be documented, but these are going to be very, very shallow. And then on your right-hand side, this is a partial thickness burn. This is basically an area where the outer layer, the epidermal layer, has unfortunately been destroyed by a thermal injury, and now you have exposed dermis here in this case. And so full thickness wounds, these are wounds where, as you can certainly appreciate, we have gone down now through the dermal layers all the way into subcutaneous tissues and often beyond. This first patient on your right-hand side, this was a very unfortunate patient, surgical patient who was obese and unfortunately developed calciphylaxis in the wound bed. And as you look at it here, you can see this open, full-thickness, dehisced surgical wound with extensive tissue damage. There is a lot of necrotic tissue in the wound. That is one very good example of a full-thickness wound. The other wound on your right is a pressure injury. This was an area that developed in the sacrococcygeal area, and this was a patient who unfortunately had many complications and subsequently developed what we would call a stage 4 pressure injury as a result of multiple medical problems and certainly being a very compromised host. But you can see in the picture on your right, you've actually got full thickness damage, you've got exposed subcutaneous tissue, and also as you look at this wound, there is some exposed bone in the base of the wound as well. So other examples of full thickness. On your left, you can see this is an illustration of a patient who had a groin abscess. It was a cutaneous groin abscess, underwent IND, and unfortunately the wound became very infected and ulcerated, and now we see that there is a full thickness wound with extensive tissue damage again. We have penetration down into the subcutaneous tissues, and you can see that there's some necrotic tissue as well in that wound. On your right is another full thickness wound. This is a patient with a chronic leg ulcer, and we have a very, very involved wound that has a lot of almost hypergranulation in that wound. We have erosion through the cutaneous layers, and basically what we're looking at is some exposed subcutaneous tissue. So pressure injuries, as I had mentioned, this is really the most current terminology. And the NPUAP is the National Pressure Ulcer Advisory Panel. And last year, they really convened a number of experts to come together and really look at the whole concept of pressure ulcers versus pressure injuries. And they've really made quite a few changes in the terminology. But the most important things, perhaps, to bring up is that as of January 2017, pressure ulcers are now referred to as pressure injuries, and this is a very important distinction. And the reason for that is that pressure injury simply means that the tissue is injured by pressure or friction or shear forces. And it is important because sometimes there is this idea that injury means that someone is to blame. And pressure injury is not meant to assign blame or in any way imply that the injury was caused by anything other than the health of the patient rather than by healthcare providers. So that is a little bit of a controversial issue. And again, if you get into some of the wound literature and you go to different seminars, you may hear some more discussion about that. But it is an important distinction to know that we are now referring to pressure ulcers as pressure injuries. Pressure injury is really considered to be a more accurate term than pressure ulcer because some presentations of this phenomena are not open wounds, but yet are considered tissue injuries. And as we talk about the different stages, particularly with the deep tissue pressure injuries, that will make a little bit more sense to you. In terms of pressure injury staging, we really have stage 1, 2, 3, 4, deep tissue, and unstageable. These are the current terms that we are using in terms of our staging terminology for pressure issues. Now, you might notice on this particular slide that instead of the Roman numerals, those are now being replaced by actual numbers. So instead of stage Roman numeral 1, we have stage 1, stage Roman numeral 2, we have stage 2, and so forth. And again, in your documentation, that's going to be very important to make sure that you are accurately reflecting the correct stage of that wound and also noting it correctly. So let's look at some examples of a pressure injury stage 1 ulcer. You can see on your left-hand side, this schematic is showing you an area where you have some damage. The skin is technically not open. The skin is still intact. But what we have here is an area of non-blanchable redness. And the way that you would really determine that is by looking at a patient. You go and you walk into the patient's room, you're evaluating the patient, you turn them over, you see this really large red spot on their sacral area, and you depress that with your finger. And that depression should cause, if that is not an injury, if the skin is still intact, that depression should cause just an area of blanching, and we call that blanchable erythema. That is not indicative of a pressure injury. However, if things are not addressed and the patient doesn't receive the benefit of good care, that could easily progress to a stage 1. But with a pressure injury stage 1, what you're seeing is an area of non-blanchable erythema. The thing that can be very misleading is that in patients that are darker complected, and you'll see on your right, sometimes those stage 1 ulcers may not be quite as easy to determine. And because of that, it's always important as part of your assessment not only to look but to palpate as well. As I mentioned, stage 1 is non-blanchable erythema of intact skin. And then keep in mind that in patients that have darker skin tones, you may see areas of discoloration and warmth, tenderness, and possibly induration. And what I mean by induration is that when you palpate, that tissue feels firm. It doesn't have that normal softness or tissue suppleness that you might see otherwhere in the body. It's firm, it feels different, and that can be a harbinger of some further damage. So again, very important to keep in mind and make sure you're paying attention to. This is again to try to explain the concept of blanchable versus non-blanchable. When you take a gloved finger and you press on that area, if you get blanching, if you get a whiteness with that pressure, we call that blanchable. If you do not get that whiteness, we say that is non-blanchable. And that is the main distinction. If it's blanchable, it is not a stage 1 pressure injury. If it is non-blanchable, then it is indeed a stage 1 pressure injury. And if it is a patient who is darker in complexion, it may not be that obvious. However, what you may recognize is that there may be some induration, some warmth, perhaps some tenderness to that area as well. So always look and feel. Stage 2 pressure injury. This is where we have now gone through the epidermal layer and we are now into the dermal layer. And this is considered a type of a partial thickness wound. And if we look a little bit more closely at a couple of clinical examples on your left, we have an open, actually it's not open, it is a wound that has a serous-filled blister. So a serous-filled blister over a bony prominence or under an area of friction pressure or shear is considered a stage 2 pressure injury. Another example here on your right is an open partial thickness wound where again there is a penetration into the epidermis and dermis, but not into the subcutaneous tissue. These wounds typically are very shallow and there's usually no appreciable depth to them. Stage 3 pressure injury. Unlike stage 1 and stage 2 pressure injuries that we usually refer to as partial thickness, stage 3 pressure injuries are full thickness. At this point, we now have quite a bit of tissue damage. We've gone all the way through the epidermal and dermal layers, and now we're into the subcutaneous tissues. And if you look at this on your left-hand side, you'll see a classic example in this schematic of a stage 3 pressure injury. We have gone all the way through the epidermis and dermis, but we haven't penetrated the fascial layer. That's the main difference. The wound on your right is showing you what is referred to as a stage 3 pressure injury with a pibili. A pibili is kind of a great word. I think it's a great cocktail party word. I love the word. But it's a really great way to explain the concept of rolling. One of the things that will happen in full thickness wounds, not partial thickness wounds, is that typically there are some circumstances where as the wound is healing, sometimes the edges, rather than coming across the wound and healing in a normal manner as you would expect them to, will sometimes roll or curl under. And when that happens, in normal wound healing, which we'll talk about shortly, usually in the final phases of wound healing, we will get resurfacing of the wound. And as the cells, the keratinocytes, migrate across the surface of the wound, once they touch each other or come in contact with each other, we call that contact inhibition. And that is a message to the wound. That's a signaling that tells the body that that wound is closed, and so no further epithelialization or healing is really required at that point. But unfortunately, with a pibili, the edges curl under, and that same contact inhibition occurs, and unfortunately it is a false signal to the body that that wound has indeed healed when it hasn't. So one of the things that's very important as clinicians is that we would go ahead and go in there and try to free up those edges, do a little bit of debridement to allow that wound to continue to heal and progress forward. And this is showing you just on this schematic in the center there is a picture that just shows you again an area where the margins of that wound, the edges of the wound are not flat, that they're starting to roll or curl under. So that is a stage 3 pressure injury. So this is a couple of examples clinically for you of a stage 3 pressure injury. The wound on the top is, again, an ulcer, or injury rather, that reflects full thickness tissue loss. We have exposed subcutaneous tissue, and if you were to take a cotton-tipped applicator and slide it under where the edges of the wound are, you would find that those edges are not attached, and we refer to that as undermining. And I will demonstrate that to you a little bit later in this program, exactly how that looks and how you would measure that clinically. The wound on the bottom, the ulcer or the pressure injury on the bottom, is a stage 3 pressure injury. And this is a heel injury that has occurred in a patient who unfortunately ended up with some vascular issues, immobility issues, and now we have a wound that is full thickness in depth. The main difference between a stage 3 pressure injury and a stage 4 pressure injury is that with a stage 3, you have gone all the way through the dermal, epidermal layers, you're into subcutaneous tissues. But the main distinction between a stage 3 and a stage 4 is that with a stage 3 you have not gone past the fascia layer. And as you'll recall, the fascia is a protective covering or coating over the muscle. Once you have penetrated that fascia, now you are looking at a stage 4 pressure injury. And with a stage 4 pressure injury, you may sometimes have exposed bone, tendon, you may have hardware exposure in some cases. Usually this represents extensive tissue damage. And as you can probably appreciate, your stage 3 and stage 4 pressure injuries are the most challenging for us to try to treat. Here are a couple of examples for you clinically. The wound on the top is an elderly 90-something-year-old patient who developed a full-thickness pressure ulcer during a hospital stay. And if we were to take a Q-tip or sterile applicator and insert this into the wound, we would find that she has quite a bit of undermining and tunneling. And we will demonstrate that later, as I mentioned. Below we have an elderly gentleman that was found down at home, had been laying in a position for a prolonged period of time, and ended up with a very large, almost dinner plate sized wound on both of his hips actually. And this is a wound that we're seeing after some debridement has occurred in the wound. But we certainly have, as you can appreciate, extensive tissue damage. We have exposed muscle. And as you would imagine, a very, very challenging wound to try to manage. So we've talked about the stages. We've talked about stage 1, pressure injury, stage 2, pressure injury, stage 3, and stage 4. The other important type of a pressure injury to discuss, and this is really starting to get more and more recognition because these can sometimes be very ominous wounds. These are the deep tissue pressure injuries. These are usually described as an area of purple or maroon localized area of tissue damage, and this is usually a result of underlying pressure, friction, or shear, or a combination of forces. And what's ominous about these is they look very ischemic, very dark, very purple. They are unfortunately kind of a harbinger of further problems. And sometimes what we see with deep tissue pressure injuries is that even when we are doing all of the care that's appropriate, because of that underlying damage that's already occurred, it continues to manifest itself. And what we see is that even when we have a great plan of care and we are doing all interventions that we need to be doing, that unfortunately this wound will actually get worse before it gets better. A couple of examples. This is a sacral area. And as you can see in this particular wound, we have an area of extensive ischemic damage. We have this maroon, deep, dark purple discoloration. There are a couple of open areas. Now keep in mind with a deep tissue injury, a deep tissue pressure injury, the skin may be intact, but what we're looking at is this just very dark purple, very, very ischemic. And often these will progress to full thickness wounds with eschar. Also keep in mind that if you see a blood-filled blister, a serosanguinous filled blister, that is also considered a deep tissue pressure injury. Now you recall previously when we looked at stage 2 pressure injuries, we'd mentioned that a serous-filled blister is considered stage 2, whereas a blood-filled or serosanguinous filled blister is considered a deep tissue pressure injury, and that's an important distinction. The other type of injury is what we refer to as an unstageable pressure injury. And basically what this means is that you have a wound. We know that it's full thickness because typically if there is non-viable or what we call necrotic tissue in the wound, then generally that is a wound that has a full thickness or extensive tissue damage. And we say that a pressure injury is unstageable if we're not able to visualize the base of the wound. Because again, when we're staging, we are trying to describe the level of anatomic damage that we are looking at. So with an unstageable wound, we can't really see the base of the wound. And because of that, we would recognize that as an unstageable. And that's perfectly acceptable to document in your notation. If you cannot see the wound base, it is obscured by slough or eschar, then by all means it is completely appropriate to document that as an unstageable. On your left, just as an example, we can see this is a full thickness wound. We have exposed subcutaneous tissue and muscle, and you can sort of see in the base of the wound there's kind of this plug of eschar. So we really don't know. It's kind of hard to tell if this is a stage 3 or a stage 4 pressure injury. And so because of that, we can't see the base of the wound clearly, then it certainly would be appropriate to call this unstageable. The one on your right is also a full thickness pressure injury. And as you look at this, you can see that the base of the wound is for the most part obscured by slough. And because of that, we can't really determine the depth of that wound. And so again, it is perfectly acceptable to describe that as an unstageable pressure injury. So in terms of staging, again, the National Pressure Ulcer Advisory Panel, as well as other leading experts in the area of wound care, have come to the conclusion that the staging system is probably the best that we have in terms of trying to describe and document pressure injuries. And the NPUAP, National Pressure Ulcer Advisory Panel, is really taking the lead in this case, as well as the Wound Ostomy and Continence Nurses Society also endorses this current staging system that we've just discussed. But even so, there are some limitations in the staging system, which I'd like to just briefly discuss. One of the things that can sometimes be very misleading is a stage 1 pressure injury. It may be superficial or it may progress very rapidly to a full thickness wound. So anytime you see something that is indicative of pressure damage, a pressure injury, it is something that you always want to take very seriously. As I mentioned, if the wound base is not visible, then you cannot stage it, and it is perfectly acceptable to document that wound as unstageable. We never reverse stage wounds. If you have a wound that you have identified as a stage 3 pressure injury, and you have developed your plan of care, and you are continuing with your interventions, and you see that the wound is improving, you see that the wound is becoming more shallow, the wound is decreasing in size, the patient seems to be improving as well, we would not reverse stage that wound. We would not say that it has gone from a stage 3 to a stage 2. And the important reason for that is again, when we stage, we are describing the level of anatomic damage in that wound. So a stage 3 is a full thickness wound, whereas a stage 2 is a partial thickness wound. And so again, never reverse stage. Reverse staging can also get us into some difficulties from a legal perspective as well, because if you have one nurse that is documenting a stage 2 and another nurse or clinician that's documenting a stage 3, that can really cause a lot of muddiness or lack of clarity in the documentation, and that can certainly raise a red flag, unfortunately. Staging, as I mentioned, is only applicable to pressure injuries, and unfortunately I have seen diabetic ulcers staged as pressure injuries. I have seen open wounds and vascular ulcers staged as pressure injuries, but keep in mind that staging is only applicable for pressure injuries.